Brilliant. Unfortunately, there's a lot of data in this talk, which I don't enjoy, but it is what it is. So, we're going to get started. So, thanks for the invitation. It's a pleasure to be here today. So, this is a weekend special, right? Friday night inferior STEMI. And here we have 3 STEMIs, 3 RCAs, 3 different patients. And the question is, what do we do? How do we manage these cases? So current guidelines, and I think pretty much most of us, if not all of us in this room, will agree that thrombus aspiration for every single STEMI is not the right thing to do, right? So what do we do? And where does this come from? It all started off with a single-centered prospective trial called TAPAS. So the TAPAS trial, published in the early 2000s, was a single-center trial with 1,000 patients randomized to standard PCI or thrombus aspiration with PCI. And what they do is they pass a wire and take the thrombus aspiration catheter and then proceed with PCI. All stents were bare metal stents. Everybody got clopidogrel, and part of the design was to use a GPI. So in more than 90% of cases, received a glycoprotein 2B3A inhibitor. And interestingly, they had better procedural outcomes. A lot of these trials had better procedural outcomes. So better myocardial blush with aspiration, better ST segment resolution, lower incidence of pathological Q waves. And they showed better 1-year outcomes for both cardiovascular death and cardiovascular death and myocardial infarction. Subsequent ESC guidelines suggested that it is reasonable to do thrombus aspiration in STEMI, giving it a class 2A indication. But then came a larger trial. So the TASTE study was a multi-center trial with 7,000 plus patients. Again, randomized to standard PCI and thrombus aspiration, but left GPI use to the operator discretion. Now they used more DES, which is consistent with the practice at the time. But this time, as we saw in many other studies subsequently, there was no difference in mortality, no difference in MI or stent thrombosis or stroke. And at 1 year, there was still no difference and no improvement with thrombus aspiration. They did a sub-study to look at different aspiration catheters and found no difference between the different catheters, although this was not randomized, so we interpret this with caution. So the subsequent ESC guidelines downgraded thrombus aspiration to a class 2B. And then came a landmark study, which is the total study. Now, this is a much better designed study. More than 10,000 patients, multi-center from 2010 to 2014. And they had a very nice protocol. So they ensure that the guide catheter is well engaged to try and minimize loss into the aorta. Once you cross through the wire, they use an export catheter for all of their cases, the same catheter. You follow it with a thrombectomy catheter every time. If you're unable to pass the thrombectomy catheter, you dilate with a small balloon and then you do the thrombectomy again. They would apply suction before crossing the lesion, and after they remove the catheter and they ensure that after they remove the aspiration catheter, they ensure to aspirate the guide. So this was what most of us were doing at the time when we started to do our thrombus aspiration, to try and minimize the stroke risk. PCI protocol allowed bailout thrombectomy, which occurred in 7%. So here, 45% DES, again, reflective of the times. Most patients had clopidogrel because at the beginning of that study, that's what was being used. But towards the end, there was more ticagrelor or prasugrel, although there's no data on how much they were using. There was some heterogeneity. So the patients in the thrombus aspiration arm arrived to hospital slightly later than the other patients, may play a role. And the GPI usage in the thrombus aspiration arm is lower than in the standard PCI arm. In terms of procedural outcomes, ST segment resolution was better in the thrombectomy group. There were lower rates of distal embolization, but there were the similar rates of TIMI3 flow, and there were similar rates of no reflow. And in terms of clinical outcome, no better, right? So same MI, same cardiovascular mortality at 3 months and at 1 year. All-cause mortality the same at 1 year. And the results were consistent regardless of the degree of thrombus burden. However, there was a concern about stroke. So even though the numeric value was small, there was statistically it was very significant. So there's a 0.5% increased risk of stroke. And this mostly happened early. So the subsequent guidelines reflected this and downgraded again to a class 3. Now the guidelines do not say that you're not allowed to do thrombectomy. What they do say is it is not the first thing that we would do, and we wouldn't do it in every single case. But it does allow bailout thrombus aspiration if there's a huge thrombus burden after reestablishing flow. The CHEETAH study is not a major trial. It is not even a randomized trial. It is a safety study, and it's a post-marketing registry, single arm in multiple centers in the US. So 400 patients who came in with mostly with a STEMI, 87% STEMI, with a very heavy thrombus burden, were treated with a Catherex thrombectomy device. GPI use was asked to the operator discretion. In terms of procedural outcomes, and that's the main purpose of this study, procedural outcomes, the distal embolization rate was considerably lower than in other studies such as TOTAL. The TIMI-3 flow was considerably better than TOTAL, and quite importantly, the myocardial blush grade was considerably better than TAPAS. It wasn't reported in TOTAL. So it appears that it appears to be superior in establishing flow and in thrombus removal. In terms of 30-day outcomes, the MACE rate was 3.6%. You compare that with nearly 7% in total. It appears to be relatively safe. Again, this is non-randomized data. This is purely a safety registry. There were 3 reported strokes out of the 400 patients. One patient had a stroke 20 days post-procedure, so the authors mentioned that it's unlikely to be due to the procedure itself. One patient had neurological signs prior to the procedure, seen by a neurologist prior to going to the cath lab, and had a subsequent MRI showing a stroke. And one patient had difficult anatomy requiring multiple catheter engagements. So we go back to our studies. We go back to my cases. Our first case, our second case, and our third case. This is what they look like after we pass the wire. So do we treat the 3 patients exactly the same way? Not necessarily. So the first patient had a very low thrombus burden, standard PCI, balloon stent imaging, and the final result, we didn't have to do any aspiration, and none of us would do aspiration in a case like this. In my second case, I used the balloon initially, but this caused significant embolization and it blocked the distal PLA, which is a large branch. So I did bailout thrombus aspiration using the Catherex. I took my catheter all the way down to the distal PLA and took this big lump of red thrombus from the PLA. Re-established TIMI-3 flow, fairly good myocardial blush, and then OCT-guided stenting to the RCA with 2 drug-eluting stents. The final case, the moment you pass the wire, you can see there's a very large lump of thrombus. And in this case, we opted to go with upfront thrombus aspiration. And this is not against guidelines. The guidelines do allow you to take a thrombus aspiration catheter if there's a large thrombus after crossing with a wire or with a balloon. So here we cross with the wire, massive thrombus. So we do our thrombus aspiration, and we do an OCT once we establish TIMI-3 flow. And our OCT shows no dissections, no plaque rupture, but mostly plaque erosion and thrombus. So we don't do anything at this stage. We just put the patient on a prolonged GPI infusion and bring it back in 3 days. And we repeat the OCT in 3 days. Now you can see up front that the thrombus burden is much lower, and we can see that there is still some plaque erosion and some thrombus, but there's no luminal obstruction. So my MLA was 6.6 when I did this case. So the lumen is reasonable. We actually did not stent this patient. We treated him with medical therapy. It's 2 years down the line and he remains event-free. So in summary, initial trials suggested that there may be benefit from thrombus aspiration, but this was refuted by larger randomized control trial that to date have shown no survival benefit in thrombus aspiration routinely. Having said that, all of those trials allow bailout thrombus aspiration, and that occurred somewhere between 5 and 7%. So there is still a role, and that may well confound results. Newer technology, particularly the Catherex that I use in my cath lab, appears to be more effective in thrombus removal. Now, this gives us better flow and gives us better myocardial blush, but does it affect outcomes? We don't know. Nobody knows yet. This needs a big randomized trial, and this will happen, but so far this is just hypothesis generating. Thank you.